Dear colleagues and friends, good morning, afternoon, evening, wherever you are in the world. Welcome to this International Fetal Cardiology web course, which is divided in two parts. One running now for a couple of hours, and one next Wednesday at the same time, in agreement with your time lag that you have in your country. This international course has been organized by the Price International School based in Florence, the Wayne State University Medical School based in Detroit, and the Semer Institute based in Perugia, Italy.
So without waiting too much time, I would like to introduce the first speaker, which is Professor Graziano Clerici, which is based in Perugia. He is a maternal fetal medicine specialist and is running the European Center for Medical Research and the International School of Ultrasound Aesthetic and Ecology based in Italy, in Perugia, and he has taught to many student residents how to scan ultrasound for the last, I think, 30 years. So he is particularly indicated as an expert to start dealing with how to start examination of fetal heart, and of course, standard planes are one of the basic things that you should know. Graziano, thank you to be with us, and to you the podium.
Thank you very much. Good morning or good afternoon, depending on your geographical position. I would like to start my presentation by briefly thanking the organizers of this important course, and particularly Professor Giancarlo Di Renzo, with whom I shared all my professional life, and Professor Roberto Romero, who kindly hosted me to work with this group many years ago in Detroit. I thank them for choosing me to give my contribution with the extraordinary colleagues who have inspired me and who still inspire all of us in the wonderful field of prenatal diagnosis, such as Gregory Devor, Rabbi Chawi, Giuseppe Rizzo, etc. It is a great honor for me to take part in this event with so great experts. Thank you again for this wonderful opportunity. And now I will start my presentation by focusing on the methodological aspect on how to obtain the main scanning planes for the evaluation of fetal heart. So before starting the examination of the fetal heart, I want to share with you some preliminary consideration. And particularly, I suggest, before starting the evaluation of the fetal heart, to choose an appropriate preset of the equipment and try to improve it when you are confident with the machine. We have to recognize the fetal line and position, evaluate the position of the placenta and of the fetal spine. If necessary, try to obtain or improve the acoustic window, particularly try to avoid the shoulder, arms, spine, and ribs shading. Try to obtain, when possible, both apical and transverse view of the fetal heart. I will show you the reason why I am underlining this aspect. And try to obtain as much as possible the main scanning planes that you are seeing here, the four-chamber view, left and right outflow tract, the three-vessel trachea view, the arches, aortic and ductal arch, and the vena cava view. To help you in the evaluation of fetal heart, I want to show you a technique, very simple technique that I call the shoulder technique, that can help you in avoiding the shoulder, arms, spine, and ribs shadow. As you can see here, the preliminary aspect is to look at the alignment between the head and the body of the fetus. They should be in the same position in order to avoid some traumatic event for the fetus. When you are sure that the head and the body are in the same position, you can engage, pushing your probe, the achievable shoulder, and try to push rotating and try to rotate the body of the fetus. I will show you here the technique. Sometimes it's very easy. I'm checking the alignment between the head and the body. I am engaging the shoulder and the pushing. As you can see, in this way it's possible to change, to rotate the body of the fetus and to have a very good view of the fetal heart. Not every time is so easy, but it is possible, and I suggest to try to apply this technique every day in your clinical practice. So, before starting in evaluating the main scanning plane for the fetal heart, I want to suggest that we have to start for the examination of the upper abdomen. Remember to evaluate this part of the fetus and the position of the abdominal organs, and then the correspondence with the left and right side of the heart. This is very important in some cases of isomerism in order to make the diagnosis of the challenging situations. So you can see here the main scanning planes that we can evaluate after the evaluation of the upper abdomen. The most important, all of you know, that is the four-chamber view. But as I will show you, we need to evaluate other scanning planes that are very important. The left and right outflow tract, the three-vessel and trachea view, the ductal arch, the aortic arch, and the vena cava view. And I will show you the methodology to get this different scanning plane. As I told you before, when you are scanning the fetal heart, when possible, it is very good to obtain the perpendicular and the apical view of the heart. Why? Because you know that the longitudinal resolution, the ultrasound, are greater than the lateral resolution. So in transverse view, for example, you will see very clearly the septa, the intraventricular septum, the atrial septum, the lateral wall of the heart, but you can't see very clearly, for example, the atrioventricular valves. You can see very clearly here the septa, and also in this perpendicular intonation, you can see very clearly also the moderator band. This is very important for the identification of the right ventricle. Here you can see underlined the heart cavity. So in apical position, longitudinal, as you can see here, it's very clearly evident the apical portion of the wall, the heart, the atrioventricular valves, and the wall of the atria. And this view is visible very clearly the two inferior pulmonary veins that are going into the left atrium, and you can see very clearly the atrioventricular valves, the mitral and tricuspid valve. So when we are able to obtain the four-chamber view, what we have to look for? This list of points are very important, and we have to look every time to all of these points. We have to look that the heart is to the left of the chest with the apex pointing at about 45 degrees forward and to the left of the chest. The heart is above the diaphragm, and there are no other abnormal structures in the chest, for example, the stomach. The area occupied by the heart is about a third of that of the thorax. Both ventricle and the atria are present, have approximately equal size. The ventricle occupies the apex, the left ventricle occupies the apex of the heart, like you can see here. The moderator band is visible toward the apex of the right ventricle, and these two last aspects that are very important in order to identify the left ventricle and the right ventricle. The intraventricular and intralateral septa are present and they appear intact. The atrioventricular valves are present and they appear normal with a slight displacement of the medial edge of the tricuspid valve toward the apex. You have to see the present disposition of the pulmonary veins, particularly, as I told you, in this kind of view, in the longitudinal view, and you have to check if there is no pericardial pleural effusion. That sometimes is a sign of heart anomalies, but also in general or fetal pathology. In the last point, you can see I put the present regularity and position of the coronary sinus. Why? Because I think it's easy to get, it's easy to evaluate, and can help you in the identification of the left side of the heart in some cases of isomerism. I will show you in this short scene loop all the aspects that I showed you before. You can see here the coronary sinus going to the right atrium, very close to the mitral valve, identifying the left side of the heart. You can see the atrioventricular valves, as I told you, with a slight displacement of the medial edge of the tricuspid valve toward the apex. You can see the ventricles that have approximately equal sides, with the left ventricle forming the apex and the right ventricle under the sternum with a moderator band. Now you can see the atria that have approximately equal sides, with the foramen ovale and the septum primum freely floating into the left atrium. You can see the two posterior inferior pulmonary veins very close to the descending aorta, very close to the left atrium. So you can see that many fetal heart abnormalities are diagnosable in the four-chamber view, and the main ones are the ectopia cordis, cardiac dislocations, ventricular hypoplasia, single ventricles, cardiomegaly and or hypertrophy, large intraatrial or intraventricular defects, valvular pathologies, Epstein anomaly, cardiac tumors, anomalous pulmonary venous return, particularly in the apical view, and it is possible to see the pericardial pleural effusion. But you can see here many pathologies, sometimes very challenging, are not diagnosable in the four-chamber view, and this aspect pushes us in the evaluation of the scanning plane of the fetal heart. The main ones that are not diagnosable in the four-chamber view are the tetralogy of Fallot, the transposition of great arteries, truncus arteriosus, the double outlet ventricles, left and right, the stenosis, atresia of the aortic or of the pulmonary valve, and some pathology of the aortic arch, like coarctation, interruption, right aortic arch or double aortic arch, and so on. So these pathologies, as you can see, represent a real challenge in prenatal diagnosis. Why? Because they are difficult to diagnose before birth, and particularly they are not diagnosable in the four-chamber view. They are correctable after birth. Their diagnosis is crucial in choosing site, time, and mode of delivery. So their diagnosis is crucial for prognostic and medical-legal issues, as you can understand. So starting the examination of the fetal heart, I want to give you this message. Keep in mind this very simple movement. Tilt the transducer from the four-chamber view toward the fetal head. In this way, you can get all the main scanning plane of the fetal heart. And in the meantime, when you tilt the transducer, you have to rotate a little bit to the right or to the left shoulder, and you will get the outflow tracts scanning plane and also the transversal and trachea view. I will show you the methodology. Looking at the left outflow tract, how we can get, starting from the four-chamber view that all of us are able to obtain. You can see in red the ultrasound beam that is parallel to the diaphragm, because the position of the heart in the fetus is horizontal. So you have to maintain the probe in this alignment, and from this position you have to tilt the transducer, look at the ultrasound beam toward the fetal head, and slightly rotate to the right shoulder. This is the way to get the left outflow tract. Keep in mind these two images. Here you can see the movement of the probe, tilt and rotate to the right shoulder. This way you will get the left outflow tract. You can see, you can check the continuity between the intraventricular septum and the ascending aorta. You can see the appearance of the aortic valve during diastole, the mitral valve that is opening now, and during systole, the mitral valve is closing and the aortic valve is opening. So, with this simple movement, very thin movement, you can get the left outflow tract. What about the right outflow tract? From the same position, because we know how to get the four-chamber view, you can see here we have to tilt the transducer a little bit more than before for the left outflow tract, but in this case we have to rotate a little bit the ultrasound beam to the left shoulder. I will show you here the movement. You see, tilt the transducer or the fetal head, and in this case rotate on the other side. You see here, to the right shoulder of the fetus. And here you can see very clearly the right outflow tract, the right ventricle, the pulmonary valve, the main pulmonary artery, the right branch of the pulmonary arteries, and the ductus venosus here, very close to the descending aorta. So here you can see the schema of action in getting the left and the right outflow tract. Tilt the transducer, rotate to the right shoulder, you will get the left outflow tract. Tilt a little bit more and rotate to the left shoulder in order to get the right outflow tract. So now we are able to obtain the left and the right outflow tract. But what we have to look for? We have to look to this aspect. We have to recognize all these aspects, and particularly that the aorta arises from the left ventricle and the pulmonary artery from the right ventricle. We have to look and to evaluate the disposition of the vessels, and we have to recognize that they are crossing vessels. As you can see here, the ascending aorta is going up and the pulmonary artery is going down. We have to look at alignment, particularly in the left outflow tract, in order to see the continuity between the intraventricular septum and the ascending aorta, to exclude some intraventricular septal defects. We have to look into the sides of these two vessels that have approximately equal size, with the little predominance of the pulmonary artery, with a ratio about 1.2 to 1. We have to see the continuity of the vessel and the number. No additional vessel, no less vessels than normal. Here you can see the methodology to get the three-vessel and trachea view. And as you can see here, I suggest to start from the right outflow tract, because now we are able to get the right outflow tract. So starting from this scanning plane, you can see you have to tilt the transducer a little bit more increase the inclination toward the fetal head, but you have to reduce a little bit the rotation to the left shoulder. You can see here, look at the hand and the probe movement, starting from the right outflow tract. You have to push a little bit more and to tilt a little bit more toward the fetal head and reduce very slightly the rotation, as you can see here. This way, you can get the three-vessel and trachea view. You can see here the pulmonary artery, the aorta, the superior vena cava, and the trachea. Here is the scheme of action in getting the three-vessel and trachea view. Starting from the right outflow tract, you can see here the ultrasound beam, tilt a little bit more and reduce the rotation to the left shoulder. So now we are able to get the three-vessel and trachea view, and it is time to say what we have to look for. We have to look the number of the vessel, the disposition of the vessel with the pulmonary trunk, ductus arteriosus, and the aorta with the isthmus line to the left of the chest, with the trachea and the superior vena cava to the right. The dimension and appearance of the vessels with, as I told you, a little predominance of the pulmonary trunk to the aorta with a ratio of 1.2 to 1. And using color, we have to use color in order to see the direction of the flow. That should be the same. I'm closing in showing you how to get all this scanning plane.
Tilt and to rotate to the right, and then tilt and rotate to the left.
Tilting a little bit more to get the three-vessel and trachea view. I will finish my presentation with a scheme of action in getting the aortic arch and the ductal arch. As you can see here, from the three-vessel and trachea view, I suggest to start from this scanning plane. You have to make the alignment with the pulmonary artery, and when you are in this position, you have to turn the transducer on 90 degrees. You will get
the ductal arch.
In the same way, you can get the aortic arch, making the alignment, going a little bit more laterally to the right shoulder with the aorta. In this way, when you are in this situation, you can turn the transducer and will obtain the aortic arch. Finally, I will show you the methodology to get the vena cava view, and I suggest to start from the aortic arch. You can see here in the three-vessel and trachea view, the superior vena cava is very close and to the right of the ascending aorta. So you have to move the transducer laterally to the right shoulder, and when you are with an alignment with this situation, you have to
turn the transducer on 90 degrees
in order to see the venous return into the right atrium. So thank you very much for your attention. I am very proud to be part of this important meeting, and I'm ready for any question. Thank you again.
Thank you very much, Graziano.
I hope to be
easy. You make easy something that is so difficult at the beginning, but I think that with the schema that you show, the people are already introduced very well to this, difficult examination of fetal heart. As I said, the question will be at the end. You can write the question in the question and answer panel that you have. And we move to the second presenter, which is Dr. Gustavo Abella. Gustavo Abella is from Ecuador, but he lives in the United States. He's a computer scientist. He's inventor of several, applications for ultrasound machine. He's president and CEO of the major platform based in New York. He's a passionate in introducing this kind of methodology in our arena. And I will invite also, and just remind you that also next Monday, we have another course which will be dedicated to simulation. And also this course, the simulation tool has been introduced by Gustavo. I would like also to remind that Gustavo now will introduce this methodology, and methodology will help many of us and of you to navigate in the fetal heart and to try to understand what Dr. Clerici has show you that may be complicated beginning. The system is called FINE, Fetal Intelligence Navigation Echocardiography. As I said, you may have some channel in YouTube run by Lamier, and you can may look more deeply about this, but I ask Gustavo to introduce this model and to give his presentation now. Thank you very much, Gustavo, to be with us.
Thank you, Dr. Di Renzo. Before starting, I would like to say, Professor Clerici, that I am very, very much impressed by your presentation, because you pointed out the necessity to try to obtain a posterior spine positioning on the fetus. And we strongly believe that this is of extreme importance for fetal echo. So sometimes the lateral approach could make impossible the arches, and the exclusion of the arches is like blinding the eye for echo diagnosis. So I really believe that what you are showing that looks simple, it's the way to go. So now I will start with my presentation. Can I share my screen? Okay. Good. Is my screen visible?
Yeah, we can see it. It's okay. Go ahead.